Anyway, welcome to the second evening of Just Because We Can, Should We, in relation particularly to medical procedures. And I'm Father John Gainey. I'm a Paulist priest. I'm the Director Emeritus of Catholic Information Center and also the Rector of the Cathedral of St. Andrew. And our discussion group this evening is, wait a minute, let me talk about this for a minute. Is Margarita with us? Ah, Margarita, sorry, didn't see you. We'll begin with a prayer as we always do here at the CIC.
Good evening, everybody. My name is Margarita Solis-Dio. I'm Director of Dominican Center, and I thank you for inviting me to open up this session with a prayer. If we could just take some moment of silence just to center ourselves and ready to hear the conversation this evening. God, you number our hairs and determine our days. You hang the stars and feed the sparrows. You open doors no one can shut, and shut doors no one can open. Surely we can trust you when the time comes for making big decisions, or for that matter, any decision. We will trust you for generous wisdom and peaceful hearts. How we praise you for being the decision-making God. It is not our decisions, but yours that make all the difference. We will plan, but we trust you to order our steps. We will pray, but ask you to fix our prayers en route to heaven. We will seek counsel, but count on you to overrule faulty or incomplete input for our most trusted friends and mentors. We will search the scriptures, but not looking for proof texts, but for you. Free us from the paralysis of analysis. Free us from the assumption that there's only one perfect choice in any given situation. Free us from making decisions primary for our comfort and others' approval, or fear their disapproval. Free us to know that good choices don't always lead to the easiest outcomes, especially at first. God, you number our hairs and determine our days. You hang the stars and feed the sparrows. You open doors no one can shut, and shut doors no one can open. Amen.
Amen. Margaritas, thank you very much for your prayer. And while some of you are still settling in here, including apparently the leader of the group here tonight, we were just about to say that you were late, but you weren't. So good for you, getting through all of that in Ann Arbor, et cetera, et cetera. So we're delighted, as I said, to have all of you here this evening. And our panel discussion this evening is about something we really don't think about very often, and that is end-of-life questions when you are dealing with children, because we just don't think that that will ever be a question until it happens to us or to our families. And it does happen. I have a cousin in England, and he's only 2 years old now. But when he was born, it was very touch and go for many, 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 many months. And now he's better, but still faces a very long life of some very difficult situations. So it's real, and it's something that we need to deal with ethically and also at the medical level. Our panelists tonight include, and I'm going to start right here at my left, immediate left, which is Brian Pilkington, who is an ethicist and also a philosopher from Aquinas College. Then Ken Pittich, who is our presenter this evening from the C.S. Mott Children's Hospital in Ann Arbor. Then Sheila Schindler, who is from the Hospice of Michigan. Sheila and I were discussing the common bond that we have in the name Sheila. And you may wonder, why do you talk about that? Well, because my sister's name is Sheila, that's why. And my grandmother's name was Julia, and that's why my sister was called Sheila. And if you don't know why that's all about, I can tell you, it's an Irish thing. The word for Julia in Irish is Sheila. So in our family, there are many, many Sheilas following all the wonderful situations that we have in Ireland, that you got to name the first child after the grandmother. That's in the old days. Doesn't happen anymore. I got all hung up there on Sheila. Leaving me to introduce you also to Dr. David Dickens, at Helen DeVos Children's Hospital. I often talk about the children, not the Children's Hospital, because they are, well, everybody in all these hospitals is just wonderful. But I will tell you the experience of a pastor when you were called at 3 o'clock in the morning to go to the Heart Center at Spectrum. And you go in through the door where the security people are, okay? And then they make you walk all the way through the hospital so that you have a heart attack before getting to the people who are involved. That was one of my colleagues said to me, "Are you sure that's not what they're trying to do?" I said, "I'm pretty sure that's not what they want." But anyway, so we're delighted to have everyone here this evening, and we'll begin with Dr. Petich helping us with the first case.
Hi, thanks. I'm sorry I didn't get a chance to meet everyone, including my sister who came here, who lives in the neighborhood. But I'll hang around afterwards. I'm delighted to be invited to be here. I have two cases. One really comes in three parts, each with its own kind of interesting challenge, both practically and ethically, and sometimes even legally. This is a case that Dr. Dickens and I both have encountered patients just like this. So this is not the real name, and some of the things have been changed to obscure the true identity of this person. But we're going to call her Tiffany. She's a 15-year-old girl that was just diagnosed with a high-risk type of cancer. Her parents have looked this up in various websites and talked to people that are in their circle, and they are asking their oncologist to prescribe and help them manage an alternative therapy other than the kind of standard chemotherapy plus or minus radiation therapy that might be in this teenage girl's future. The oncologists know that standard medical therapy for this kind of cancer has a greater than 50-50 chance of inducing a remission, meaning that she'll be without cancer, without treatment for at least several months. But this cancer is high risk, and the long-term survival is likely to be quite less than that, even maybe as low as 20%, even with the most aggressive kind of therapy. So the parents come to the physician saying, "We would really like to try this alternative therapy, which we think is, has a better chance, we think, from what we're looking at, of curing her, even though the medical training of the people who are now confronted with this situation, really have nothing to base confidence on anything except the treatment that they've been studying and using and know that has some proven benefit." So I'm not sure who would like to respond to that one first. Do the parents have the right to pursue for their 15-year-old child a therapy other than the one that is being recommended by their oncologist?
I'll start with the answer, and I want to first acknowledge that I would welcome the opinions of anybody in the room. We happen to accumulate an audience which has a combination of personal experiences and professional experiences that may be very similar to this. And rather than having a didactic one-way conversation that will be recorded, I would encourage anybody who has an opinion about it, whether you work in this field or not, to share it. As a pediatrician, we're often called upon to always make decisions in the best interest standard of the child. So parents are given the right to make decisions for their children as long as it's consistent with a best interest standard. what one considers to be in the best interest can be sometimes value-laden determination, where this kind of conflict can come up, where what I would think as a medical professional is the best interest and what the parents think is in the best interest may not be on the same page. So the right starting point for this would be to try and align people's treatment goals. It would be quite common in this time where people will collect information from sources that may or may not be valid. And sometimes we'll take a common case of like immunizations. When people have a philosophical objection to immunizations, they've collected information that wasn't necessarily correct, and studies have shown with further education, we can provide the family with enough information where we actually wind up aligning our best interest goals. So in these scenarios, the first attempt will be to try and share information with the family to understand where they're getting their information from. Assuming that doesn't happen to run with this case and you're still dealing with a family who decides that they want to pursue an alternative therapy, then we as in the oncology world have to assess whether the overall risk and benefit leads to an acceptable treatment pathway. That doesn't always work out to be the case. Sometimes you would make a determination if some are coming at you with a treatment regimen that you thought would be harmful, then that pathway would take you from out of the case, and the standard would be then you can either at your institution review it amongst your group, bring it to an ethics board, or refer the patient to another hospital where maybe they may feel the same way, but there's this subject called physician autonomy that allows a physician to not prescribe treatment that they do not think is in the best interest of the patient. So the physician is never obligated to do this. However, the reality is that often requires the family, if they're pursuing alternative therapy that you're not going to ascribe. Commonly, other hospitals will feel the same way with standard therapies because we use the same resources. And these families commonly would wind up traveling. Then you have the hypothetical 15-year-old patient going with one parent, flying to a different state and going back and forth for their alternative therapy with a terminal prognosis, while the hypothetical other children are going to never see their terminally ill sibling again, nor their parent who is taking their sick child to the other hospital. So there are unintended consequences of pursuing alternative therapy when you are not in agreement with it and you decide that you want to cut yourself out of the equation. And sometimes, however, the alternative therapy is not thought to be harmful. There are some alternative therapies with a terminal prognosis that don't appear to be upsetting the balance between risk and benefit. And we have in practice helped a family guide them through those alternative treatments, knowing that a standard of care may have a temporary benefit, but not improve the child's long-term prognosis. So there are different pathways we can walk down, and again, to just rephrase what I said, we try and align our treatment goals, provide the education that we think is necessary to align those treatment goals. When not possible, we try and decide for ourselves, is this parent acting in the best interest of the patient with this decision? Would a reasonable person make the same decision, which is another standard that is used? If not, refer them to another center, an ethics board. If it seems reasonable, then the physician can decide for themselves with their autonomy whether they want to continue to participate in the prescribing care of that child.
Sheila, as the social worker here,
Yes.
what would you do in this particular case? How would you work with the doctors
Okay.
and the patient?
Okay, I hate microphones and cameras, so I promise I will do my best. Okay, as a social worker, my code of ethics is really primarily the family, and to give them all the tools and support they need to make the decision that's best for them and their child. So in this case, I think they need time, if we have the luxury of some time. Absorbing information like this is really rough. And they need, as Dave was talking about, accurate information. The internet and family and friends can be overwhelming and frightening. So a dad comes to mind, and what he said to me makes so much sense. He explained it really well. He said this was shortly after his daughter had been diagnosed, and she could have been Tiffany. She was 14 and she had cancer. And he talked about how when she was very, very young, she had been swarmed by bees and was forever terrified of bees. And so shortly before she was diagnosed, of course, everything comes at once, a bee's nest had formed right by their front door, and she was so petrified. What they did is they went and they got books, and they got accurate information, and he said together they started studying these bees until, even though she was terrified, she could still look at them and almost be fascinated by them. So he said, this is how we're going to approach cancer. We're going to learn accurately whatever we need, and we're going to absorb it, but it takes time. So as the social worker, my role is really to give them, make sure they have that accurate information, make sure they have the time, take care of some of those everyday stresses, like finances or childcare with the siblings, or lawn care. I mean, our team, I work with wonderful people, and they will help this family. I've sat with many nurses who are on our team for 4 hours having these discussions over and over again with families. So give them what they need, and most of all, I think they need hope. That's what moves them forward. And right now they're hoping that the alternative works, and maybe with all this support and guidance, they will move forward, which I think, and the medical people can correct me, but in my experience, families move along. They change. And I think this family is going to change. So,
Brian,
that makes sense.
reaching for the microphone.
Thank you. I was actually going to ask Dr. Dickens a question, just for a clarification, because I appreciated both the sympathetic approach, but also to understand harm better. And it seems like the physician is put in a very tough spot. And the toughest case might be, and I have no medical background, I just hang out with docs. The tough, so it's a question from a novice. So we learned that the alternative therapy, there's no confidence in its effectiveness. So what do you do how do you think about harm if it's the case that you don't think this is going to make someone worse, but there is a treatment which looks like there's a good chance? And if you could just say more about that.
Sure.
Thank you.
I think if I'm understanding this right, maybe an interpretation of the word harm may be false hope. I heard Sheila say the word hope being important. And in this case, and there are real cases in which standard care will not lead to a hopeful situation. So in these scenarios in real life, what I find is really happening in the dynamic is the family is hearing from the medical team, when you cut through all of the medical lingo, your medical treatments can't cure my child. Then they get out there and they hear different stories about treatments. I think Sheila's comments also elaborated a little bit on what I said about aligning goals. We start off in a different spot because what they hear, people hear what they're listening for, and what they hear from alternative people is, I can fix your problems, don't listen to your doctor, without any of the bad side effects from chemotherapy. Because there are people here who work in our field, chemotherapy is a poison. I have a license to poison children. We cut them, we burn them with radiation therapy. These are unpleasant things for me to disclose to a family and say, this is your only hope to cure. Now, when the odds are good, most families, after they work with somebody like Sheila, will accept the fact that they have not a choice between something good and bad, but something bad and worse, and will pick the lesser of the two. But there is a harm in alternative therapy if there's a significant difference in the outcome between the standard of therapies. And that's when a pediatrician has to act. If this were a case where we had a highly curable disease and the family came at us with an alternative request, the family would then be, we would be then getting more of a ethical and legal posture to conclude that the family is not making decisions in the best interest of their child. In this case, it's a little bit more muddy. So if I'm offering them toxic chemotherapy that's going to have a chance to land them in the hospital, and they have this therapy with some unknown benefit and unknown side effect profile, not everybody does this. I take it upon myself to learn as much as I can about whatever that therapy is and make an independent determination before I walk in the room of what I would do if I were in their position. Because the only thing that's stopping me from being one of these parents is very scary. I don't know. Nobody knows what causes these things. Kids don't ask to be there. They didn't do anything to deserve it. And we don't understand what causes them there. So before I walk in a room and make a recommendation that a parent does something with their child, I've already determined what I would do if I were in that position. And there are some terrible decisions these people need to make. But if you have a choice between getting chemotherapy to give it a try just because that's what we do it, or there's somebody out there who has an alternative therapy that they believe would at least not harm the child and at the end would lead to no better of a prognosis, you then have to struggle with our ability to determine somebody's prognosis because there's still so many uncertainties. No two tumors are alike. And so prognostic uncertainty is a huge challenge in this issue, isn't it? Because I can't tell for sure who's going to make it or not. I've trained myself to understand as best as possible. But you could take the worst of cancers out there, and it's rare that in a pediatric cancer, the chance of being cured is 0. Maybe they get down to 10%, single digit kind of things, but there's always exceptions. And as medical advances have progressed and stories go out of people who've beat the odds, you raise the bar of expectations higher and higher, and the next family have to walk on that tightrope at an even higher level than the ones before them. Hope and expectation plays a big deal in this work. And the hope and expectation for every child walking in is that we're going to cure them, and the reality is it isn't. And Father G had mentioned at the beginning that this is a fairly uncommon scenario. To put a number on it, in the United States, for every 100 people who die, 1 to 2 of them are children under the age of 18. 100 years ago, does anybody know this statistic? What that was 100 years ago? It was about 40%. Almost half of everybody who died was under the age of 18.
I wouldn't be surprised at all.
Before antibiotics, infectious disease played a big role in the influenza epidemic of 1916, 17, took a lot of kids. And so it would be fairly common, even 2 generations ago, where everybody would know somebody who had lost a child. It was more of a societal norm. But accepting that the medical system does not have a cure for you in 2016 seems unfathomable. And most people, if you tell them there's nothing I can do to cure you, will not accept that and find something else. And as I said, there's harm with the potential unknown. There's also harm in saying and wiping your hands clean of it and saying, I don't want to be involved, because the reality is you know that they will go to the ends of the earth. That's the societal norm. Surveys have done to parents who've lost children and said, what is your role as a parent? Well, how would you define being a good parent of a child who has a terminal disease? And it was some comment to the effect of turning over every stone, making sure I've tried everything that's reasonable. And nowadays, there's a lot of information out there that seems pretty reasonable, and people will continue on with their therapies. That was a very long-winded answer to a very pointed question. I hope I actually responded appropriately to it. There's a lot of uncertainty.
I shared this case with a colleague of mine down in Ann Arbor, and they said, oh, I've got one that was a little similar, but with a twist. a child with another serious cancer, but with a slightly better than 50-50 chance of cure with common therapy. But the alternative therapy that was being pursued here was actually a trip to Lourdes in the hope of a miracle. Does that change the advice that you give to someone? And Father, I'd be interested if that family came to you asking for your advice, how would you frame that for them?
I think a lot of that depends really on your belief in miracles. And do you believe that this is really going to happen? And I would think also that a trip to Lourdes is pretty short. By that I mean, why not take the trip while we're preparing the therapy? I don't know many situations in which you find a therapy that has to begin that fast. At least that's not my experience.
There are occasions where it would be, but we would work pretty strongly to facilitate that as soon as possible if in fact we needed to start therapy. So I don't see those principles as being mutually exclusive. But in these scenarios where you have a good prognosis, this is a hard part of being a pediatrician when a family is going to choose a path that is going to significantly diminish the child's chance of surviving because of their belief system. There are times where we have to intervene and set up a medical foster care situation, and it's hard because the child's just diagnosed with cancer, and I'm sure there's no intent on doing harm by their child, and their belief system is that whatever alternative path they're going to pick is going to cure. But in our determination and our role in society to protect children, we occasionally have to override a parent's decision if it's more clear that it's going to sacrifice any chance that the child will survive.
The story continues. Tiffany receives the standard therapy along with some non-harmful alternative therapies. This was not the one that went to France. And after several months of this intense therapy, she goes into remission and stays relatively healthy for a year. Goes back to school, develops good relationships with her friends, but at age 16, she relapses. This time, the family is on board with therapy since the therapy a year ago did produce a good remission that lasted for almost a year. So she gets a bone marrow transplant without initial complications from her fully matched younger brother. This time, however, her relapse only lasts for 4 months. She's offered high-intensity therapy this time, and now the parents are on board, thinking that anything that we can do to help extend her life will be good. This time, however, Tiffany, who will turn 18 in less than 6 months, says, "You know what, I'm done. I don't want any more treatment. I just want to have summer to spend time with my friends. Don't give me any more therapy." She's still 17.
Your turn.
If the question of consent is the relevant question, and we're going to parse 17 and some number of months to 18, this is no legal claim. I do moral philosophy. I don't do legal philosophy. I'm not sure what the difference is between a 17-plus-year-old and an 18-year-old. I'm also not sure that the number of years is the relevant qualification from a moral standpoint. Aristotle worries at certain points in the Nicomachean Ethics that you have to have experienced certain kinds of things in order to be a proper person to talk about this stuff. And he's very clear it doesn't matter the number of years, but it's the youthfulness of character. So I suspect someone who has gone through what this young woman has gone through has experienced a great deal such that she is much more mature than I would expect other 17-year-olds. So if it's 17 or 18, I don't think that does much work. But again, I don't do legal stuff.
With regards to my knowledge in the legal area, and we have lawyers in the audience, you're welcome to speak up. There is a term called consent that we've been talking about at age 18 or emancipated minor, which this case is not, most aren't. But there's also a concept of assent, A-S-S-E-N-T, which means that a child in this age group would have to agree to participate in any therapy. I can't strap a 17-year-old down to a bed and infuse them with chemotherapy against their will. So this child is not assenting to therapy. I agree with your statement about, with regards to a psychological and developmental perspective on pediatrics. There have been documented cases down to age 8, 9 years after the age of reason where conversations and understandings about death and dying and consequences of decisions can be documented in children that young, probably related to their experiences. Some kids in that age group have been through chemotherapy for many years. We can even go younger than that in our clinic and have experiences which many people in this audience can probably share of children as young as 3 and 4 who have terminal illnesses, who talk about things that are beyond their years with regards to their interactions with their family, the things that they see, the things they believe, they think understand, and it's often remarkable the type of conversation you can have at a young age. So I would agree, at age 17, the legal system has got the biggest problem with this, and as the guide in this situation, people like Sheila often get involved. Again, the concept is to align goals, to understand there's a very complex psychology in adolescents and young adults who have terminal illness. It's very different from children and different from older parents. They're at a different developmental stage. Oftentimes, the adolescent and young adult would be making decisions to not be perceived in a way that they're afraid of being perceived. We do a pretty good job, again, as a societal norm, to militarize our experiences with cancer. We have a war on cancer. People battle cancer, they fight cancer. Abraham Verghese is famous for talking about this subject, and that is empowering at the beginning. But as you probably know also, hope is a good breakfast, but it's a bad supper. When you're at the end of your battle, and things are looking more bleak. When you are feeling like you're ready to give up, oftentimes that can be viewed by societal norms as being, you failed. You weren't strong enough. You were in a battle and you walked away and you gave up. And that makes it even more complex. In this situation, which is a little bit more unique, most times in practice, the child is agreeing to keep going because the parents are keep going, and the medical providers are recognizing that maybe we're going a little bit too far. And studies have also shown that it's more often than not that a medical provider would admit to anonymously participating in the care of a child that went beyond its futile point. So in this dynamic, the child is saying, let me stop, and I would have to understand why the parents aren't agreeable to listening to their 17-year-old and their desires. Oftentimes, I think in practice, it's a fear of letting go, a fear of what the grief is going to feel like. I think when you know you're going to experience grief, it's hard to prepare yourself adequately, and a lot of times I think that the parents have a role to protect their children, and when they come to the realization that that's not going to happen, it's very difficult to prepare yourself properly for that, and they're agreeing to therapy or wanting therapy, not because they think it's going to cure their child, because intellectually they can understand that. It's feeling very ill-prepared to deal with the grief and the loss that they anticipate.
One of the things, though, I think in terms of moral theology would be that we have a kind of a sliding scale when it comes to children. That oftentimes we are, because we're so protective of them, helicopter moms and dads, that we forget the fact that they are human beings, and they do indeed have intelligence, and they do indeed have decision-making capabilities. So the closer that we get to the, quote, golden age of 18, the more we are inclined, and more, again, as moralists, to look at the situation and say, this young person is clearly capable of the decision about his or her own life, and therefore should be allowed to make those kind of decisions. You get down into this 6 and 3 and 2, that's a different story altogether. Then they are not able to do any of that kind of stuff at all. the in-between years are the tough years. And most of these decisions, including the ones we were talking about last night, and in terms of adult death, and the decisions that are made for these younger people are never clear. I mean, it would be wonderful if we could say, oh yeah, that one's an easy one, right? None of these decisions are easy. All of these decisions are very, very difficult.
All right, I'm a social worker. Here I come again. I think it's awesome that she's rebelling. Okay, she's a teenager. It's probably the most healthy thing she's doing right now. It means she's not depressed or giving up. So I think the key for teenagers is to listen to them, hear them out, and make sure they have what they're looking for. So her developmentally, she wants to find her own way. She wants to be independent. She wants to join with her peers and have a good time. And she wants to, the kids that I've worked with, like Tiffany, they want everything from to go to prom, to not be embarrassed by adults, to get a tattoo. I mean, they need to be heard out. And I think that can help a tremendous amount. I think also with Tiffany, she's got, her family needs to have enough so that the parents, one of the fears is regret. They don't want to regret not doing something to save their child. So I think if a family has what they need, if the child has what they need, the teenager and the parents, then okay, I'm a social worker, but I really believe things can come together, and that is part of my job. I work with families, the nurses work with the families to come to some kind of joined agreement. Can I tell a story? Because there's a wonderful example of how this worked in a community, and the importance of community is not something I want to leave out here. This was a kid who, much like Tiffany, had cancer, was getting more isolated, and things had gotten worse. And they were having some of these back and forth about treatment versus being home isolated and getting out and being with friends. So Tiffany wanted very much to be able to get out and do her own thing. And so we worked with the family, and the parents asked me to work with the school because that was really the crux of the connection that was at the problem. So I called the school, told them what was happening. The next afternoon, the nurse and I drove out to Tiffany's house, and it was probably the most rewarding moment of my whole career. In her front yard was the entire school community. It was the principal, the teachers, her friends, the counselors, her extended family, and then in the parking lot across the street from Tiffany's house was the entire high school band. And they were playing, and the ground was shaking. It was so loud, and people were dancing. And the dad called me over and said, last night I didn't think I could do this because I'm not a strong person. But looking around today, I realize that even though I'm not strong, we are strong, and we are going to get through this. And that effect of the community was so powerful that kid was connected all summer. They were able to go through with treatments, and the most powerful thing I think happened was she was able to set up a scholarship in her name because she said, because I'll probably never go to college, I want my friends to go to college. And so she was able to be productive and form an identity and have, which is why we're here tonight, right? I mean, we can talk about theory, but really the next step is helping these families and supporting them, and community is so essential. So I'll just throw that in.
I thought you didn't like microphones and cameras.
No, I don't.
Doesn't seem that way to me.
Much prefer to back off, but.
Your disclosure should have included, instead of being camera shy, that you are a master magician with families who enter hospice, particularly in the adolescent and young adult group, because we've been through many experiences where you prove that oncologists can do a much better service to families by incorporating end-of-life care discussions early on, so that we can help these families establish meaning in their life if the inevitable is going to be that they're going to die. So we as oncologists need to find a way to teach ourselves how to send that message with families without being sending mixed messages or reducing hope out of their equation. It historically is very difficult for oncologists to do. If we're waiting till this point in the case to have a discussion about end-of-life care, it's probably already too late to be effective, because the emotional content of the situations rise, and it becomes increasingly difficult over time to have an effective transition into end-of-life care, meaning-making type behaviors. The problem is nobody wants it. So you can very well recommend it early on in the care, and people say, no, thank you, that's not for me. If I know the family you're talking to, I think that was the exact response. I think this was a patient I cared for, and they didn't want anything to do with the conversation the first time, the second time, the third time, and how you manage that effectively. It just takes a little time to have that. So I would recommend at this point that it should be mentioned that we should try and do a better job at helping families incorporate legacy building for especially adolescents and young adults earlier in their care, because they may miss an opportunity that held so much meaning, long-lasting meaning for this family. It's just extraordinarily difficult to do when you're managing a family whose hope and expectation is that you're going to be there to cure them as an oncologist.
All right. Are we, the next step here, we're gonna, sure, let's move on.
We can move on to the story yet continues. Tiffany refuses treatment, has a few good months, but then gets sicker with her cancer with lots of pain, and returns to the hospital for pain control, and is ready for a transition to hospice. During the days that she was in the hospital, however, because she had lost weight, she was started on artificial nutrition and hydration. And when she's finally stable from a pain standpoint and is ready to go home, and the hospice team talks to her about what services they can offer at home, her parents raise the question of the discontinuation of her artificial hydration and nutrition, and actually use the phrase that we've probably all heard in the hospital: we know she's dying, but we don't want to let her starve to death. Can you please continue the artificial nutrition and hydration? Who wants to take that one first?
Yeah,
I vote for Brian.
yeah, right.
So artificial hydration and nutrition is tricky. And with respect to any medical act, I think we defer to the best medical practitioners. Why nutrition and hydration is tricky is because we might want to describe this not as a medical act, though surely feeding tubes are medical, but feeding a person is a human act. And so it raises different kinds of questions. And that's what's hard. If there's any instance in which a medical treatment is no longer effective, if a body is no longer taking on nutrition, then it seems like it's futile, and starvation doesn't seem appropriate. However, if a body is still taking on nutrition, and again, I defer to the medical practitioners for what's going on in terms of health. If a body is still taking on nutrition, and it's not the case that the treatment is overly burdensome, it's tough for me to say to discontinue the feeding tube. So I'm curious what people who know much more about this have to say.
I feel like I've dominated the microphone, Ken. I'm happy to give my opinion, but I want to make sure you have a chance to chime in.
Weigh in on these questions, Sheila?
You go right ahead.
I can tell you practically how we usually approach these, and a lot of what Brian's saying is, is a big part of the background. We look at. I was a general pediatrician for 20-some years before I kind of got into the palliative world and end-of-life world, and like many people, I'd already been practicing for almost 20 years before I'd ever heard the term pediatric child palliative care and hospice in the same paragraph. I didn't know that existed, and it was a family actually from Grand Rapids who had been receiving hospice services as an infant, had severe brain injury, and was discharged from the hospital into hospice care, and the family moved closer to where I am in Ann Arbor because they had grandparents close by. And I actually had to get my ethics colleagues together, and this was more than 15 years ago, to help give me advice about how to deal with this. And gradually I became less afraid as a professional of helping people through the difficult transition from expectations of a healthy child in a normal life into a life full of challenges and visits back to the hospital and the emergency room, a downhill spiral towards more and more discomfort, admissions, ICU admissions with breathing tubes, attempts at CPR, some kids that would have to get poked 15 times when they came to the ER to get an IV in, to give them hydration and antibiotics. And the ability to accept the fact that we couldn't fix everything, is a challenge that's facing medicine, even, as much today, but in a different group of patients. Instead of those 40% of children dying before the age of 18 100 years ago, now we still have 150 kids that die in my hospital in Ann Arbor, children that die in the hospital every year, and another several dozen that die outside the hospital that we've taken care of. And the fact that to figure out not only how to accept but to help them through this is very, very challenging, but can be very rewarding if there's a team around that can develop the relationships that can really, really help. The hydration and nutrition question is exactly what Brian says. If the therapy is providing a benefit, great. What our kind of stock answer to the phrase is it providing benefit? If someone has advanced cancer, there is a really good chance that the nutrition that we're giving is actually feeding the cancer and not the patient. And so unless somebody is in somehow benefiting, they're receiving other therapies that are keeping the cancer at bay, that's something that we can certainly tell parents that that this is not helping your child, or to say, Tiffany, this is not helping you. Starving, that question comes up all the time. To me and to my colleagues, starving means to withhold nutrition from someone who is capable of, who wants it and is capable of benefiting from it. When people are dying, I think when it's my turn to be either sick or really old and dying, I think I'm going to probably lose my appetite, and to be forced to have things forced into me when I'm not hungry. But we do this all the time, and it becomes really normal. I think right now of 250 kids in the Mott Children's Hospital in Ann Arbor, there's 75 of them who have a feeding tube today, and most of them are going to benefit from it. But at some point, it's not going to benefit everyone. So we use that rationale along with the support when we need to of our chaplains, who can help us explain to people the same things that Father and that Brian have explained to them. But it still can be really hard, and sometimes it's a process. Well, let's turn the feeds down and see if she's more comfortable, because excess fluids make it hard to breathe. They make you feel uncomfortable. So it's not uncommon to be able to move slowly down.
Yeah.
I'm wondering if we could have
would be happy to do that, although I think frankly these gentlemen are doing very well. But the major thing that we have to be aware of is that as Catholics or as Christians, and I believe that most faiths actually, believe in an all-loving and a merciful God. We are born to die. We forget about that. A child is born to die too. Not as early as they are in this particular case, but nevertheless, that's the reason that we are born. We are born into the world to go to God. So if you believe that, if you have faith in that, then a number of these issues can be solved. One of the things I think we really have to be aware of is that we are given to the idea that life extends from the moment of conception until the time of natural death. The question here is it natural to be having people with tubes inside themselves being fed so that we can say we didn't starve them? We didn't always starve them. Now, a child is much different, and I'm not necessarily too good at pediatrics, but in an older person, we know that a natural sign of dying is you don't want to eat, and so you don't. And that does indeed help move the needle, and it moves that needle toward death. The same thing is true of hydration. If the hydration helps, for heaven's sakes, yes, of course, apply it. If the hydration does not help, and it probably won't, then you can stop. These things don't have clear-cut answers. And there was an attempt a couple of years ago at the time of the death of Pope John Paul II to kind of muddy the waters a little bit when it was a document was given to the Pope who never proclaimed it, never promulgated it. And the document said, no matter what the case, you've got to hydrate, you've got to feed. And interestingly enough, when he was dying himself, he did not do that, nor did his doctor recommend that. So it's one of those areas that still remains somewhat muddy, and I always appeal to the long history in the church of our moral theologians who said, you know, you do not do any harm, and weigh the idea of burden and benefit. Is there a benefit? Apply. If there's a burden, now we have to talk. So that, I think, is where our church stands at the present minute.
Another question in the front.
So I'm actually a parent that faced this decision with my infant daughter. We were cared for out of state. We just recently moved back, but I'm curious, in the scenario where it's not cancer, but our daughter, for example, had a terminal degenerative disease, spinal muscular atrophy. And the scenario comes up for the benefit of the crowd, the muscles eventually deteriorate. So the first ones to go is often ability to swallow. So I'm curious, in your institutions or in your experiences, do you guys have issues with a family that knows there's no cure? The infant may not be struggling at the moment, may not be in a lot of pain at the moment, but the decision to use a feeding tube is, in essence, prolonging life and prolonging what further declines will come. And do you guys have objections to a family withholding and feeding early on in that stage?
I maybe should repeat the question for the purpose of the microphone. I'll summarize what the gentleman in the audience had said. If I heard you right, you have lost how many children? One child is a disease which is a lot like Lou Gehrig's disease in kids. So if you just think of those scenarios. And the question was, okay, so in cancer, the risk-benefit ratio may not be so favorable for an end-stage cancer patient. For somebody who has a disease like that, there's no clear end prognosis time. And the child may survive for an undefined period of time. Ultimately, something will happen that's life-threatening. Is it a different ethical situation when you're dealing with a different disease that has a more prolonged prognosis? I also want to add on to earlier comments that have relevance to this. When Pope John Paul II was dying, Terry Schiavo was dying at the same time. This is 2005, so if you can wheel back into 2005, there's a lot of rich discussion in the news media because both of those scenarios were playing out. Pope John Paul II had end-stage Parkinson's. And after he had got a tracheostomy for apparently repeated pneumonias, he had commented on the legal determination on the Terry Schiavo case. She was in a permanent vegetative state. I believe it was the husband wanted to withdraw the nutrition and the parents didn't want it, and so it created a lot of legal debate. And he had declared at that point that that was not the correct decision. And in preparation for this, knowing I was at the Catholic Information Center wanting to educate myself, I had to remind myself where these things came from. So if you wouldn't mind obliging, I looked up the source document for where this came from, which I'm sure you both know. It's a catechism of the Catholic Church, which we often reference to and is used in medicine because it's so well defined on what a moral basis is for these decisions. And I'm gonna have to read it because my eyes got dilated by ophthalmologists in my reading glasses. Discontinuing medical procedures that are burdensome, dangerous, extraordinary, or disproportionate to the expected outcome can be legitimate. It's the refusal of overzealous treatment. Here, one does not will to cause death. One's inability to impede it is merely accepted. Shortly thereafter, it says, even if death is thought imminent, the ordinary care owed to a sick person cannot be legitimately interrupted. And that's where I believe he came down on the Terry Schiavo case in the way that he did. And it comes down in how do you define what ordinary or extraordinary means? Is the provision of artificial nutrition and hydration ordinary or is not? Women are born with a letdown reflex. When a woman gives birth and her baby cries, she has a reaction that creates food. We're programmed to feed and hydrate our children. And in those scenarios, the standard is still the same, but the formula is different, the variables is different. Parents, as long as they're making decisions in the best interest of their child, are able to determine whether or not they feel there's an overall net benefit to that hydration. And if that net benefit is prolonged existence, biologic existence, whatever value that has for you as a parent would be considered an appropriate measure for that child. And in our practice, we would not be withholding that. That being said, if another family in their value set believes that in their assessment of the overall net benefit of the patient, then it would be permissible for the medical team to withdraw it. So the parents are given the task to determine the value of the human existence. Philosophers, you can correct me if I'm wrong, have debated over maybe centuries over is human existence merely a biologic existence, or does it require a certain level of consciousness to be of value to protect? And I can't resolve that. I don't know if you can, but in the medical system, the American Academy of Pediatrics does defer to the medical team and the parent determining if they believe that there's overall net benefit. Now, there are risks to these things. The complication rate for artificial nutrition and hydration can be as high as 75%. Infections from G-tubes and having the tubes in your nose, overhydrating, electrolyte abnormalities, respiratory difficulties. It's not without risk, but again, as Dr. Pinich said, it's a balance between the benefit, and currently still the parent would get to decide.
And I think also one of the things that's very important for us to think about is what is ordinary and what is extraordinary. I mean, what is ordinary now in medicine was extraordinary 10 years ago.
And these are the challenges that are facing families like yours every 2 weeks. We have another degenerative neurologic diagnosis, and the same things that you had to face at some point are there. And unlike some neurologic deterioration diagnoses where consciousness seems to be very impaired and the ability to be aware and to feel and exchange, looks of love and to appreciate life is certainly there, because a spinal muscular atrophy diagnosis does not affect the brain at all, just the muscles. And now we have technology that can feed and help these kids stay breathing. And we've got kids diagnosed in infancy who now have tracheostomies and are on home ventilators for years, completely unable to move anything. These are like the old polio patients that we sometimes remember only seeing pictures of, in iron lungs, who can't move anything but who are still awake and alive. The burden that is felt by parents who face these things, this is a big part of my job now at Michigan, is to help people through that process of understanding and then having their values be elicited so that best decisions can be made. What we see happening, because the technology has outstripped our ability to catch up philosophically with these huge challenges, is the default mechanism in our hospital is to say, well, your child is not going to be able to breathe, without starting with a mask and a machine and then probably with a trach and a vent within the next few months. What do you want us to do? And that is, I think, one of the most hardest questions that I think we ask way too much. What do you want to do? Well, we want our child to be as healthy as they can be. We want a different situation than the one we've got, but here we are. We are embarking at Michigan on both an educational and a research program to try and figure out how do we best help get us all, parents, the children, and ourselves, through these difficult, challenging situations. What we're trying to promote is to really find out, what's your understanding? What are you hoping for? What else is important? What are you most afraid of? What do you think your daughter could tell us if she could talk about what this life is like and what it will be like? And on the basis of what you told us, it sounds like this is the direction we should head, that might relieve the burden from a parent. We're not sure what the right way to go is. No. We don't know, but we know that there's a lot of suffering out there, and the suffering is not just the kids who are struggling, but it's with the parents who are trying to support and be good parents despite the things that even 20 years ago were uniformly fatal, and now we can keep them going.
I think it's time for us, we haven't had any questions, well, we've had one question or two questions.
Can I just do a
Sure.
quick add-on to that?
Is this going to be 30 seconds, 60
There,
seconds?
oh, okay, I'll talk really fast. There are resources available, but I want people to know that our team can offer everything from volunteers who do family photography, or we can help with wish trips along the lines of what are your priorities. Quality of life is what we do. It doesn't have to be depressing and sad all the time. I mean, I'm sure there were moments of real joy. That's what we want to maximize and live as fully as possible. We have lots of options that maybe parents don't know about, so I wish I had 2 hours, but I don't. So I just want to say that there are options available to maximize the joy and live as much as possible. These are still kids and siblings and families, and there's joy and love. So.
I'll just follow up that I think in our experience, many other families we've got to know.
Would you do me a favor? Would you stand up and walk to the microphone so we can see and hear you?
Real quick, I was just going to commend the speakers for that perspective of engaging with the families and laying out all the options. In our personal experience, many other families that we've gotten to know, physician bias has actually ended up without the family fully knowing what all their options are at every stage along the way. And as we get to know this organization and get more and more examples out there,
That's where we see some of the biggest challenges from the patient and the family side of it. So I just want to commend that answer, is that that's of utmost benefit from the family side, no matter what way they're going to go, to at least have it all out there for them.
Thank you, appreciate that. Now we really would like you to ask some questions. So if you have a question, we would also like you to step to the microphone so we could hear from you and also be aware of who you are. Okay, so you come up and just tell us who you are and ask a question. And don't be afraid, you know, questions are a wonderful part of life. I can see people sitting there
Well,
waiting.
people are building their courage.
Courage, yeah. Not that
I'll
hard.
stall for a little bit and maybe respond. I'm sorry to hear for your loss and your experience. There is great variance in how people practice medicine, and particularly when there are difficult situations like you were in, like we were discussing. This panel has been selected probably with extreme bias in individuals who have been experienced in this area and have seen. I myself have been I've been an oncologist for 14 years and the medical director for the pediatric hospice program for 13 years. Now that we have statewide, I'm responsible for the west side of the state, and serving both roles I think has influenced my perspective on these issues, and I continue to work with families who've lost and grieved for over 10 years. When I go to meetings, oncology meetings, and we discuss issues about technology and advances and molecular guided therapies and new treatments and all of these hopes and expectations, I see the struggles in the families when they participate in it. The families who did not receive good palliative care, good end-of-life care, good guidance from their medical team, often have their grief compounded by decision-making. It's hard enough as it is with the loss, but to have to think back and reflect on decisions that you wish went different and the power of regret is even more difficult. And we do our best to educate when we can. We get involved. I know Ken gets involved and I get involved with national committees. And Hospice of Michigan, under Marcy Hillary's leadership, amongst others, have done so many things for this community and outside of this community to try and expand the reach of people who are in these situations and try and share how we can do a better job at caring for people when medicine can't cure. So we're under no obligation to cure. People hope and expect that. I'm obliged to heal, and sometimes that means that you're not going to, the patient will not survive. So we are trying to share the message, but we recognize that there is great variance in the practice of medicine. And hearing some stories from oncology colleagues and families who've not been beneficiary of good guidance, I feel that it makes a very terrible situation even worse. And I'm thankful that we have a community that provides the resources that we do. We're really lucky in West Michigan and in Dr. Pittich's community to have built resources for families through organizations like his Children's Hospital, the Helen of Voss Children's Hospital, Hospice of Michigan, to provide resources for people who need help, because and particularly for the loss of children, there's not a lot of resources. It's not a normal situation.
Okay.
Did I buy somebody some time?
All right, there we have it. See, there's a question. There you go.
Thanks, panel.
What's your name?
Scott Hawkins. And I'm just wondering, although it wasn't overtly stated in this, it seems as if once things got moving with Tiffany and with her family, there was a point that they wanted to keep that going. And I'm wondering about some of the times when, if they were to stop moving forward, that concept of giving up. And if you could address that idea of when people either are thought to be or accused of sometimes of giving up, and what your thoughts are on that.
Well, I think people are people. And one of the things that I can do right here is stagger a little bit while our friends here think together about what they're going to say when I call on them. The fact that somebody says, I give up, I'm not sure they do give up, okay? I mean, I've certainly witnessed many deaths now, not frequently, thank God, the deaths of children, but many deaths. And what we oftentimes say is, they died peacefully. Why had they died peacefully? Because the humanness in them had reached a point where they knew that their life was fulfilled in whatever way. We don't know what that is. But they were fulfilled. They were able to move from where they were in life to a better life beyond. And I think that's what gives us that sense of peace. I don't think people give up. And I don't think parents around a child ever give up. My niece has a friend in Cleveland who never, ever gave up. And I think she would frankly be much better off if at one point she realized this child is dying and going to God, and that's okay, because she's really suffered the rest of her life.
Yeah, the language that's used in these situations can be really very, very powerful. We collect phrases that we think are things that we wish people never said. And one of my colleagues wanted to do a study in our ICU where we put shock collars on the doctors. And every time they said, well, your child's going to need another round of chemo, it would go off. So but some of the phrases are, do you want us to continue to do everything? Meaning, that usually comes up when you're trying to talk to somebody, and it could be, a 90-year-old person, or a child who is really dying of their underlying disease, when you're trying to say, in this case, in case the heart stops or the respirations get labored and slow down, it's not the best thing to do to try and get them back, but to try and do everything we can to make sure that their end is as comfortable as we can. And we got such great tools now to help assure that people aren't short of breath and struggling with pain. But to say, to make this dichotomy between do everything as if do nothing, we're trying to use the terms, are we going to do aggressive, symptom control, aggressive comfort care, is what we're going to promise our patients that are signing up for hospice services. The language is really important. What was the phrase that you were asking about? Giving up. Yeah, that's one that we would like to get the shock collar on. We never give up. We change the goals of what are we trying to do. You want to get home? We're going to do everything we can to get you home for as long as you can and live as good a life as you can. We didn't get permission from our institutional review ethics board that has all these ethicists on it that said shocking people was not ethical.
Good point.
As long as we restrict it to the docs, I think we might make an exception.
Very good. Are there any other questions? Don't be shy. There's one over
Coming
there.
up
There
to
we
the
go.
podium
All
here.
righty.
Please introduce yourself.
My name is Joe Voss. Something that Sheila said, and I think has come into this thread a little bit too, is the concept of regret. And families that would regret having not done, whatever it would take. And I'm wondering if you can flip that and talk about regret around what families have done and sort of what conventional care can bring about for families, and some of the regret that comes with that when ultimately conventional care isn't going to lead to a prolonged life.
You've heard of the stage of bargaining, and there's the 5 stages, and bargaining is one of them. I think the flip side of bargaining is the what ifs. What if I had, and why did I? It's part of coming to terms with this impossibly painful situation that nobody really knows. We've heard this a few times on here. There are a lot of what ifs. Every cancer is different, every child's different, every family's different. So I don't think there is a right or wrong path, and families need to be given the tools and the support to make the best decisions at that moment. And then we provide bereavement support, which addresses a lot of that. They witnessed a lot of suffering, and I think that causes some post-traumatic stress for families. There's nothing worse than watching your child suffer. And there's even evidence that people who come back from war that have witnessed suffering have higher levels of PTSD than those who experienced some kind of injury. Parents they live in a war zone with long periods of chronic stress punctuated by moments of extreme crisis where they have to make decisions right then and there. And there is no answer. My heart goes out to them, and I think there's no Band-Aid. I think the key is being willing to go in that dark place with parents and letting them know they're human, they did the best they could for their child. People love their kids, period. That's it. And you did the best you could, and the healing happens with connection and support with other people who know and are willing to be there with you as you go through that. I hope that.
I think I know where this was going. It was tying into a letting go decision, and those families who have that difficult decision where they have a choice to pursue aggressive medical therapy and make that courageous choice to not do that. They're offered it because doctors will do it, and then they say, no thank you, because, and that's where the regret is. Because in the because lies, your child will probably die anyway. However, what we're going to do is put them through surgery, be in the PICU for a couple of months, be on medications, potentially have a number of complications, and the outcome may be no different. That is a horrible place for people to be, and some families do choose to say, you know what, no thank you. In my balance of life, the risk that people incur when they decide to pursue all treatments at all cost is the child who doesn't have the ability to choose, let's assume this is a younger child, is subjected to treatments that won't work, and the child is left with pain and suffering. And even after the death of the child, those families can have a psychological regret after watching what occurred. The trouble is they don't know that that's going to be the outcome, but if that's the likely outcome, choosing to save your child from suffering is a very courageous decision, and the regret of families who choose aggressive therapy is they watch their child suffer. It's kind of counterintuitive, but studies show that patients with end-stage diseases who enroll on palliative and hospice care survive longer than patients who choose to continue curative therapy because they're no longer receiving those aggressive therapies that will shorten their lifespan. It's a little bit counterintuitive, but oftentimes we can prolong life and improve quality by making that difficult choice to not. So there is, yes, definitely regret with families who choose aggressive therapies.
I want to thank all of our panelists here this evening. Why don't you give them a round of applause for all their work. I would also like to thank Hospice of Michigan, the Dominican Sisters, and Aquinas College, along with the Catholic Information Center, all of whom were sponsors of these 2 evenings, making it possible for us to bring all this wonderful medical skill and the philosophers and social workers and nurses together to help us realize all these important questions about life and about death, all of which are never easy questions for us to deal with and to answer. And I'd like to take one moment of privilege. There's a man in here who is the new director of the Catholic Information Center. I'd like him to stand up. Father Rene Costanza will be the guide and the leader for us for the next couple of years, God willing. And we're delighted to have him and have him share his skills and his wonderful compassion with all of us. And I'm sure if there are other questions that you did not get to ask here this evening on the formal level, that some of our guests will be here for a little while afterward, and you can probably direct those questions to them in that direct way. Amen? Amen. All right, now we'll have a prayer to close from Margarita Solostil.
I thought we would pray in solidarity with those parents who are currently praying for their own children. Strong and faithful God, my heart is breaking for my child. The weight of this situation is so heavy, it's difficult to breathe. My words choke out in fragments. Sometimes they don't come at all. Articulating thoughts requires more energy than I have, so I just sit in silence. My strength is gone. I'm anxious, God. This situation doesn't make sense to me. My child is so innocent and vulnerable. I don't understand why this is happening. Help me to trust you with my child's life, with every aspect of the situation, with all the pieces of my life. Keep me from attempting to rely on my own understanding, because there is no way to understand this. Help me trust you with all my heart, not just part of it. I acknowledge that everything in the heavens and earth, everything that is precious to me, including my child, belongs to you. Your ways are higher than my ways. Your thoughts are higher than my thoughts. You are good, loving, and faithful. It's absolutely impossible for you to do evil or to do wrong. Help me to believe this in the depths of my soul during this time. Thank you, God, for remaining faithful even when I act faithless in my pain. Your love, presence, power, and promises are not dependent on my behavior. You understand my pain. Give us strength because we are flat out weary. Help us run this grueling race with perseverance and never give up. Help us keep our eyes glued to Jesus, our champion who perfects our faith. In him all things hold together. We will depend on him to hold us together no matter what comes. Father, I love and adore my child. Thank you for entrusting my child to me. It is such a privilege being a parent. I humbly ask you to bring my child to complete healing and make my child physically whole if that's your will. If it's not your will for my child to heal during my child's time on earth, I will still love, serve, and follow you. I know that you are for us, not against us. No illness, disease, disappointment, or setback, nothing in all the world can separate us from your love. I ask you to protect my child emotionally and spiritually. Give my child the strength needed for each moment, each test, each prod, each pill, each surgery. With your great love, drive out all fear and comfort. Even though I can't see it now, I believe that in all things you work for the good of those who love you. No matter what happens, you will bring beauty from the ashes of this time. I thank you, God, for continuing to work good in me, transforming me into your image and perfecting me into the day Jesus returns. Use this struggle, Father, for your glory and renown. Thank you for being with my child. There is always hope with you. I submit myself, the situation, and my child to you, God, 100%. I trust you with the outcome. I will rely on your strength completely. I pray these things in the name of Jesus. Amen.
One last item. A thank you to our staff here at the Catholic Information Center for all their work making all of this possible. And the final, tomorrow at 10 a.m. at the Cathedral of St. Andrew, we were going to be having a day of prayer for peace that's been asked for by the bishops of the United States. Will be taking place all across the country. And also at 3 o'clock in the afternoon, we'll be ringing the bells. We hope anybody who has bells around will join us in that as a sign of peace and the need for peace in all our communities. And thank you all for being here, and good night.